Okay, so we're recording. Okay, so I thought what we'd do tonight is have a quick review over cardiac emergencies and then talk about some medications that we use to treat cardiac emergencies, and then maybe, depending on how everybody's attention span is, maybe we'll go into respiratory and whatever. We'll decide how much enthusiasm we have. Before we start, just realize COVID is a little bit on the uptick in Rockland and in some places in Brooklyn and the city. So I know, people have gotten a little lackadaisical as far as their personal protective equipment, but, maybe just to reinforce that, it is starting to crop up. I think the Muncie Spring Valley area is over 4% now. And with Labor Day and the opening of schools and the Jewish holidays and everything, you're definitely going to see a little bit of an uptick in it. So the nice thing is that the cases don't seem as severe as we had a few months back where, people were just dying right and left and stuff. So that is good. And then obviously the personal protective equipment will also help us from protecting from influenza, which is, going to start pretty soon. So, we should definitely reinforce that with everybody. And if you haven't gotten enough PPE in, it's available now. So if you haven't gotten enough PPE and everything like that in, you should definitely take advantage of, the ability to purchase it before it starts to dry up again. Okay, so from a cardiac standpoint, let's see if we can get this working. So we're going to be, just to review before we get into giving the actual medications that the difference between a EMT class and an advanced first aid class that we used to, advanced first aid used to be the EMT class before there was an EMT class. So the big difference between EMTs and people who can do first aid is that EMTs have the ability to give medications. And, every year there's additions to the amount of medications that we could give. And probably there'll be 2 or 3 more, I would think, in the next couple of years added to it. So with that right to be able to give it, or is the responsibility of making sure when it is appropriate to give it, because obviously we could hurt patients if we give them medications for the wrong situations and too much and stuff like that. So these are what they call the rights of drug administration. So we have to make sure the patient has no allergies to medications. So on a EMT level, are there any medications that we administer that we have to worry about allergies? The patient might have allergies to.
Yes, yes.
What do you think?
Aspirin.
Aspirin. So aspirin definitely would be the one that you would have to think. Now, a lot of people in this world have not taken aspirin. Probably if you're under the age of 30, you may have never taken aspirin because, again, kids are not given aspirin anymore for fever or colds or anything like that. Everything's Tylenol. So people may not have ever taken aspirin, which means they're probably not sensitized to it. But there's always that possibility. So aspirin is probably the main drug that we administer to people that we have to worry about allergies. Now, it's not to say some of the other medications may not have interactions, but as far as allergies go, pretty much on a BLS level, that's the main medication we have to worry about. Now, the right person obviously is more of a hospital type of thing when you have 2 patients in a room and you want to make sure you're giving the medication to the right patient. Typically EMS, with the exception of maybe doing a standby at an event or something like that, you typically have 1 patient at a time. If it was an MCI situation, you're probably not giving a lot of medications, right? If it's a true mass casualty situation. So that's more of a nursing thing. Right drugs. So it used to be pretty much we gave 1 drug for everything, every condition, but now obviously with the cardiac patient, we could be giving multiple drugs. Probably even the asthma patient now, we might have to giving multiple drugs, and we'll talk about that, maybe anaphylaxis even. Okay, right dose. So pretty much everything is like a 1-shot pre-mixed deal for us. But if you're doing check and inject on the epi, which I know you guys still use auto injectors, but if you're doing check and inject on the epi, you do have to know that the adult dose is 0.3 milligrams and the pediatric dose is 0.15 milligrams, which is half the adult dose. And the cutoff between adult and peds is actually weight specific. It's not age. So does anybody remember if you had to choose? Well, this even comes into play if you're using the adult EpiPen versus the pediatric EpiPen. What would be the cutoff to decide whether or not you're going to use the pediatric or adult EpiPen? Anybody have any idea what weight they're talking about?
30 pounds.
So 30 kilos or 66 pounds. So again, you're supposed to have your medications in a separate container, like a separate box on the ambulance. So it's always a good idea if somebody wants to take that on as a project, or maybe even have the youth squad do it, is to write up all the medications and all the little, notes that you need to know about them. So like, in other words, you'd have epinephrine, 0.3 milligrams adult, or whatever color your adult EpiPens are. And you could say for patients over 66 pounds, and then the pediatric EpiPen for patients under 66 pounds. This way, in an emergency situation, you don't have to worry about, trying to remember these things. Okay, now right time again, pretty much the right time would be, when with the patient again in a nursing situation, um, they have dosing, whether it's 1 time a day, 4 times a day, or something like that. So pretty much right time would be when we're, in an emergency situation when we're with the patient. And obviously we want to make sure that medications are not expired. And also importantly that we're carrying them in the right way. I know you guys have fly cars. So if you're keeping that fly car outside, you probably want to switch if you have medications in there where, I don't know if the fly car is plugged in or not or anything like that, but if they're exposed to extremes in temperature, whether it be hot or cold, you should probably change those medications out, fairly frequently. If they were baking in there, in a 100-degree day, they're probably not so potent anymore. So try to just keep that in mind, or if you know it's going to be sitting out there, maybe move the medications inside, the medication bag inside with a little note in the vehicle, just letting them know they have to put it back in there before they go out. Again, right route is for the most part pretty simple, but we'll review those. And then write documentation. So when you're documenting, and I know electronic, it's very hard sometimes to get good documentation in there, but when you're documenting, it should be clear to somebody who's reading that PCR months from now, the reason why you gave the medication. So as an example, if you're giving nitroglycerin or assisting a patient with nitroglycerin or aspirin, somewhere in there has to be a good narrative indicating that the patient had the setting of an acute myocardial infarction, they're having chest pain, something like that, so that it's clear why you gave the medication that you gave. If there's any contraindications to giving the medication, you need to make sure that you document that the patient didn't have any. If there are any vital sign requirements, then obviously you have to make sure you document that the patient had the normal vital signs. And then you want to document the time you gave the medication, the name of the medication, how much of the medication, the route of the medication that you gave, and probably your electronic PCR forces you to do all this. Where years ago when it was paper, it was, you had to remember to do it. And then obviously the patient's response to the medication, whether it be positive or negative, right? So those are some of the things you would want to document. And if you needed medical controls permission, obviously that needs to be documented in there. Okay, so terminology when we go through the medication. So an indication is obviously the reason why we give a medication. A contraindication would be a reason why we wouldn't give it, or maybe we would, have to call medical control if a certain situation arose. The action is what the medication does, which again is, the reason we're giving it. It does something that we want in the situation. Side effects are, for the most part, expected or possible things that could go, I don't want to say wrong, but things that the patient can experience when they take medications. Like we know nitroglycerin is a vasodilator. So it's not uncommon for people to get nitroglycerin to get a headache, right? But, another side effect could be that it could drop their blood pressure, where they could actually feel weak and dizzy and nauseous and stuff like that. The headache also is because of that vasodilation. So there's different levels of side effects that we'll talk about. And a therapeutic level means that we have enough of the medication, on board to do what it's supposed to do. Okay, so let's talk about some cardiac related problems, and we'll talk about our treatment and stuff like that. So the two main ones that we always talk about, on an EMT level is angina pectoris, which translates to pain in the chest, and an acute myocardial infarction, which is the fancy way of saying a heart attack, right? Acute means sudden, myo is muscle, cardial is heart, so acute muscle, heart muscle, infarction, death of the heart muscle, right? So let's talk about both of those, and then we'll talk about what's similar and we'll talk about what's different. So both of those are brought on by the fact that our diet tends to be high in fat, and that fat accumulates in the coronary arteries. It actually accumulates in all your arteries, but since we're talking about heart, we'll stick on the coronary arteries. So it accumulates in your coronary arteries, which are the arteries across the surface of the heart that provide the heart itself with the blood it needs to be able to do what it needs to do, which is pump, right? Squeeze, contract, and pump blood. So those arteries now become narrowed, okay, because of the fat. Now the body knows that fat is not supposed to be on the inside of those arteries, so it actually grows a cap over the fat. So you have a tube, right? On the inside of the tube, there's some gunk, which is the fat. And then the body grows a fibrous cap to kind of lock that fat in place. And the thicker the cap and the stronger the cap, the less likely you are to have a heart attack, because weak caps can rupture, and a rupture of that cap over the fat is what triggers a heart attack. And we'll talk about that. But let's talk about angina first. So as we get older, our arteries start to get a little clogged. The lumen, the inside of the artery starts to get a little clogged. Plus, as we get older, the arteries themselves stiffen, right? That's why angina used to be called hardening of the arteries. So calcium infiltrates the walls of the arteries, and you know that arteries have the ability to dilate and constrict depending on the condition. If you need more oxygenated blood to get to your heart, they would dilate, right? So if they're now stiff and they can't dilate, and you're running for the bus or you're in an argument or something like that, and you need more oxygenated blood to get to your heart because it's pounding a little harder, and now you can't get it because you have this narrowing of the arteries and you have this hardening of the arteries. What happens? You have a mismatch between the amount of oxygen the heart needs, okay, and the amount of oxygen the heart is getting. So when that happens, like, so right now we're all sitting, our heart needs minimal, oxygen to beat and stuff like that, so everything's fine. If we all got up and started running around the block, then we would obviously need more oxygen to get to our heart. And the way the oxygen gets to our heart is through the blood vessels. So we all know that. When you have angina, a very slow progressive disease, right, takes decades to develop. Typically, people start having symptoms in their 60s, and 70s and 80s and stuff like that. Now they have some kind of exertional event. It could be physical, it could be psychological, they could have gotten into an argument, it could be almost any type of thing, but they have some type of exertional event that increases the amount of oxygen that the heart muscle needs. Okay, and that's called myocardial oxygen demand, the amount of oxygen that the heart needs at any given time. And now because of their condition of angina, they can't get that oxygen, that more blood to the heart, so more oxygen to the heart. So their metabolism, their energy producing in their heart changes from what we call aerobic metabolism, which is making energy with oxygen, to anaerobic metabolism, okay? And that's making oxygen, I'm making energy without a lot of oxygen. So in both cases, you have the sugar part of it, you just don't have and when you have anaerobic metabolism, you don't have the oxygen part of it. Now, they're probably breathing fine as far as you know, right? You look at them, they're breathing, their pulse ox may even be normal and everything like that. The problem is more at the cellular level in the heart. So when you do not get enough oxygen to a muscle, you revert to this anaerobic metabolism and you make less energy, so the heart's not beating as efficiently as it should. And the problem is the waste product. So whenever you make energy, there's a waste product, like when the car burns gas and oxygen, right? That's what a combustion engine, it burns gasoline and oxygen. It makes a explosion to move the car. The waste product obviously is the carbon monoxide, the waste, the gases that are coming out of the back of the exhaust, and actually some water. You see sometimes water coming out your exhaust pipe, right? That's the byproduct of combustion. So when our body makes energy, the byproduct of combustion, okay, is carbon dioxide and water. And when you have aerobic metabolism, it's very easy to get rid of that. You exhale the carbon dioxide, you use the water or excrete the water. When you have anaerobic metabolism, because you don't have enough oxygen, the waste product now changes to something called lactic acid. And you've all felt lactic acid in a muscle. You were, I don't know, you had your arm above your head because you're changing a light bulb or, something, you're exercising, and your arm started to get shaky. It started to burn a little bit. Maybe you were walking fast, you got a pain in your side. So when lactic acid is in a muscle and the muscle can't get rid of it, it gives the muscle a burning sensation. And sometimes in the heart, that sensation actually is pain. That's where the chest pain of a heart attack comes. Now in the test, they always say the chest pain is caused by lack of oxygen, which is not incorrect, but the lack of oxygen causes the buildup of the lactic acid, and the lactic acid is the actual culprit of the pain. Now, once you reestablish oxygen flow to the heart, then you go back to aerobic metabolism and you don't have the pain anymore, okay? So in angina, you have a precipitating event. So you have that exertion, whatever you want to call it, but you have some type of precipitating event that increases the amount of oxygen the heart needs. Again, it could be exertional, like walking upstairs. It could be psychological. They get into an argument, or they're stressed, or they get bad news. So it could be a lot of different things. And this is your garden variety angina. There's some variant types of angina that could actually happen at rest without stress, but we'll talk about the more common one, which is the stress brought on angina. So now they get this increase in the amount of oxygen their heart needs, but they can't meet it because they have this long progressive disease of angina. So they get chest pain, okay? They probably go to the hospital, they call the ambulance the first time it happens, they think they're having a heart attack, and they get worked up in the hospital. They probably get a cardiac catheterization even, and they find out they do not have any vessels that are acutely blocked 100%, but they have some vessels that are narrowed. Okay, they, you know, they may stent those open a little bit, just like they would in a heart attack, but it won't be an acute thing. And they'll probably tell them you didn't actually have a heart attack, but you have this disease called angina, and we're going to prescribe you a medication called nitroglycerin. Okay, and if that ever happens again, you're to sit down, relax a little bit, and take some nitroglycerin. And what does nitroglycerin do? We know it's a vasodilator, so it opens up the blood vessels and tries to get more blood to the area of the heart that has that lactic acid building in. So people always ask questions like, can somebody having an angina event actually have a heart attack, right? Can an angina then get worse and become a heart attack? Well, yes, but nobody really does it, because you would have to exert yourself to the point of, you know, damaging your muscle. And most people, when they get that heavy chest pain, they kind of stop what they're doing. But let's say you couldn't stop what you're doing. Let's say it's an emergency and you have to keep on exerting yourself. It is possible to actually have permanent damage. Remember, angina is a temporary problem that doesn't really result in permanent damage. I mean, the hardening of the arteries is there, but the chest pain part of it is temporary. Once you reverse the precipitating factors that brought on the chest pain, the symptoms go away, so the emergency is over. But it is possible, you know. I mean, the classic thing is, you know, somebody's shoveling snow and it's a guy and they want to get the driveway clean. You know, they're not going to leave half of it. In the midst of shoveling their snow, they get pain and they say, well, let me keep on going, okay, and try to finish off the driveway. So it could happen, you know, that you could actually cause it. Does it happen? Usually not. Okay. Now, the more common scenario with angina is that they've had it once before. The doctor tells them they have angina. Okay. They give them nitroglycerin, and a year goes by, they never had to use the nitro. Okay. They were careful because they didn't want to have that happen again, and they've never had to use the nitroglycerin. And now something happens, and they exert themselves and they get pain. And they remember the doctor told them they're supposed to sit down and take a tablet either under their tongue or spray the tongue put the spray under their tongue, and that the pain should go away. If it doesn't, within 5 minutes, he tells them to do it again. And if it still doesn't go away in another 5 minutes, do it 3 times, up to 3 times, 5 minutes apart, the same thing that we are allowed to do. And that if still after 3 doses of nitroglycerin and rest, it doesn't go away, then you have to call the ambulance. You might be having a heart attack. So think about that guy now. He's gotten 3 doses of nitro. The pain's not away. He thinks he's having a heart attack. What's that doing to his chest pain? It's only increasing it. But what was probably the reason why the pain didn't go away? Nitroglycerin is a year old. It's been bouncing around in his pocket or his pocketbook or something or other. And depending on the form of the nitroglycerin, right, because we know nitro sublingually under the tongue, the way we give it, or we assist the patient in taking it, is carried in 2 ways. It's carried in little white tablets that go under the patient's tongue, and it's carried as a spray. Now, the difference in price between the two of them is quite dramatic. The spray is somewhere between $200 and $250 a bottle. The tablets are like $40, $50 a bottle. So depending on what your insurance is going to spring for, you may only get the little white tablets. Now, they're in a opaque bottle because light will damage those pills and not make them work, okay? And you know, that when they are carried around and bounced around, they actually start to deteriorate and break down. So maybe the reason after 1 year that this patient didn't have good results from their nitroglycerin is that actually it's just not potent enough anymore. So let's say now we come and the patient says to us, okay, I took 3 doses of nitroglycerin and it didn't help. How can we kind of assess the potency of the nitroglycerin? So obviously we could look at the expiration date. So if it's expired, we already question it, or it's close to expiration. Remember, people may not want to replace their nitroglycerin if it's going to cost them money, because they just went a whole year or maybe even 2 years never having to use it. And they're kind of saying, like, why should I buy a brand new bottle if I went 2 years and never had to use it? So I'll ask you now, how do you know, the nitro is working? What does the patient usually tell you if you gave them nitroglycerin to indicate to you that the nitroglycerin is actually working? So they feel certain things. So does anybody remember or have ever experienced it?
Tingling under the.
Good. So they get a burning or tingling under the tongue. Now, most of these signs and symptoms are more common with the tablets than the spray, but they can happen with both. So they're very good, Amanda. They get a tingling or a. So what's that? Somebody said
whopping
something.
headache.
Yeah, so I mean, especially if you've never used nitroglycerin, some people describe it as like feeling like there's knives sticking in their heads, and that's because it's dropping your blood pressure. That's also a symptom that a patient may experience the first times they're using erectile dysfunction medications, because erectile dysfunction medications are vasodilators too. So if you ever go to someone who says, I'm embarrassed to say, but I took some Viagra and now I have the worst headache of my life, and and stuff like that, that's not an uncommon side effect of erectile dysfunction medications, because originally erectile dysfunction medications were being used or being tested as a blood pressure medication to lower blood pressure by relaxing the blood vessels. And of course, in the study, I guess enough men reported that they found it easier to get an erection on the medications, and some smart marketing person said, "Screw the blood pressure. There's millions of blood pressure medicines," but there was no medicine at that point for erectile dysfunction, so became a billion-dollar product that way. It was it was a side effect. It wasn't a planned event of the medication. So yes, so the two common things would be that you get some tingling or burning sensation under the tongue, and that they get a headache. It doesn't have to be the worst headache of their lives, but they feel pounding in their head. And that's both of those things are related to the vasodilation that occurs from the medications. Okay, so that would tell you if they felt those, that the nitroglycerin probably was potent and it was working. Okay. If they didn't feel that, then the reason their pain didn't go away is that the medication was no longer potent and it's not doing what it needs to do. Okay, so I already said the dosing, which is you can give up to 3 tablets or 3 sprays under the tongue. It's sublingual under the tongue, and you're supposed to wait 5 minutes between each one. You know that the patient has to have a systolic blood pressure of at least 120. Okay, now under the tongue means that you have to get the patient to lift their tongue up. And some patients will find it difficult, especially older patients find it difficult to lift their tongue up. So if you have to grab their tongue, the only way to grab someone's tongue to lift it is with a 4x4. So you have to, with your gloves on, obviously, use a 4x4 to grab their tongue. If you just try to grab their tongue with your gloves on, it'll just slip out. You won't be able to do it. So use a 4x4 to kind of grab it. You may see your dentist. If your dentist does a good job in the examination, they should check for oral cancers. So they actually have to kind of lasso your tongue with a 4x4 and lift it up and around so they could look in the bottom of your mouth to see if there's any lesions or anything like that. So that would be kind of the way you would do it if the patient can't do it themselves. It only works if it goes under the tongue. It has to go sublingual, under the tongue, because that's where the blood vessels are, the capillaries are to absorb it. What else? So you know about interactions of nitroglycerin already, right? We talked about erectile dysfunction medications. So the state protocol says 72 hours. If they've taken an erectile dysfunction medication within 72 hours, but you're not supposed to give it to them. I know some of you might remember that in the protocol, the last protocol update, they said to ignore that, but they then corrected themselves and realized that what they said was wrong. So we don't give nitrates to people who are on erectile dysfunction medications. The 72 hours is probably a gross exaggeration. Obviously, 3 days is a gross exaggeration. I would say, Viagra is probably okay at 8 hours. The other ones definitely are probably, go a little longer, but, say 12 to 24 hours the most. But, that's what they have in the protocol. So technically you have to abide by that. Anybody have any other ideas of when they would not give nitro? So we said blood pressure has to be over 120, no ED medications. Now, just remember with the ED medications, you would think that you'd only have to worry about asking about them in men, but the active ingredient in Viagra, in all the erectile dysfunction medications, Viagra, Cialis, Levitra, is a medication called sildenafil, or a version of it, sildenafil, like that. So those medications now are marketed under different names for different conditions, and those conditions can be in men and women. And the main one that you'll see in women is something called pulmonary, like the lungs, pulmonary hypertension. So they get high blood pressure in a very specific part of their circulation, which is the right side. The blood vessels going from the right side of the heart to the lungs. That's why it's called pulmonary hypertension. So you know that the right side of the heart pumps to the lungs. And that's, again, if the blood pressure is high in the pulmonary artery, which is the main right-sided blood vessel, it becomes very difficult for the right side of the heart to pump that deoxygenated blood to the lungs to get rid of the carbon dioxide and pick up the oxygen. So these people have shortness of breath, but there's no problem with their airway, right? They breathe air in and out of their mouth into their lungs fine. They just can't get it, the blood, to where it needs to go. It's kind of like a pulmonary embolism, right? So again, in a pulmonary embolism, they're breathing fine. The problem is blood flow. It's not getting the blood to the lungs. So again, because erectile dysfunction medications relax blood vessels, they found that they do a good job in relaxing the blood vessels in the pulmonary circuit, and they relieve that pulmonary hypertension. So women can have pulmonary hypertension, especially if they were smokers. There's rare cases of young women having idiopathic pulmonary hypertension where they have nothing wrong with them. They're healthy as a horse, there's no problems, and then all of a sudden they develop this pulmonary hypertension and they don't know why. And again, they could be on these medications. It's called Revidio, R-E-V, I think it's A-T-I-O for that case. Also, they're using the sildenafil in a different name for BPH in men, where their prostate gland is enlarged, but it's not cancerous. Um, and even if they're not using the sildenafil types of medications, the alpha blocker medications that they use, you've heard of Flomax and all these things that you commonly see when you write down people's medications. Those are all being used for BPH. Even alpha blockers drop blood pressure. So again, if somebody has a history of BPH, you probably don't want to give them nitrates. And then the last, so nitro, I know I'm harping on it a little bit, but nitro is the one medication that EMTs are allowed to help a patient take that you can really screw somebody up. Remember, you're not carrying a nitro on the ambulance. It's a medication the patient possesses, and you can help them take it if they can't take it themselves. So it's the one medication, even on an ALS level, that you always have to be cautious with, because if somebody's having chest pain and you drop their blood pressure too low, they're going to have more chest pain because they're not getting enough blood to their heart. They can actually then trigger a heart attack. So the last thing to think about, okay, and this again would be a situation where, I don't know, medic 21's in Pearl River on a bad call and you're by yourself and you're going to start racing to the hospital or something like that. But if the patient's chest pain is more indicative of a heart attack than angina, which means, in other words, in angina, the pain starts to get better, right? They're resting now. The police have put them on oxygen. They're not walking upstairs. So their pain should start getting better even before you get there and start doing stuff to them. In a heart attack, the pain pretty much only gets worse, right? It doesn't get better because it's a different etiology that we'll talk about in a second. So now you're leaning more towards the heart attack patient. And for some reason, this guy has a history of angina in the past, so he has nitroglycerin. So it wouldn't be wrong to give him nitro, okay? But we talked about the contraindications, the blood pressure, the erectile dysfunction medications. Just one other thing to consider if you really think they're having a heart attack versus angina, which is when we classify a heart attack or try to localize a heart attack, we talk about which wall of the heart is involved. So, a heart attack can be a single wall, it could be two walls, it could be all the walls, but you have a front wall, a back wall, a bottom wall, a side wall. So the inferior wall of the heart is the bottom wall of the heart, and it sits right above your belly. And those are the heart attacks that a lot of times people don't think they're actually having a heart attack. They think they're having indigestion. You've always heard of heart attacks can cause indigestion. Well, what happens is, since the bottom wall of the heart sits right above the belly, and since the nerves are all going in the same kind of area, sometimes people having chest pain at the bottom wall of the heart actually describe it more as indigestion or a burning in their stomach. Now, the problem, if you have somebody having an inferior wall MI, is they really need a 12-lead EKG to see if it's an inferior wall MI, because most people do not give nitrates to inferior wall MIs. And the reason why is that the right descending coronary artery is the artery that services the right side of the heart and the lower part of the heart, the inferior wall, for the most part. The left descending coronary artery services the left ventricle, which is the most important part of the heart. That's why it's called the widowmaker, right? You don't want to ever close over your left descending coronary artery. But now we're talking on the right side. So let's say your right descending coronary artery. Now, all coronary arteries start at the aorta, right? So they start very high up on the heart, and they go across the walls of the heart. If you block it way up top, you have what's called an inferior wall MI with right ventricular extension. So picture the bottom wall of the heart, and if you curve around to the right side, that's the right ventricle, right? So if you block that artery close to its origination, now no blood is getting not only to the bottom wall of the heart, but the whole right side of the heart. And the right side of the heart is what we call preload dependent, which means it gets the venous blood back from the body, right, through the superior and inferior vena cava. So nitrates relax veins better than they relax arteries, okay, because veins are less pressure. So if you drop their pressure and you don't get enough blood back to the right side of their heart because you gave them nitro, plus the right side of their heart is damaged from the blood vessel being blocked, the right descending coronary artery, you're basically going to ensure that no blood is getting pumped very effectively by the heart, and they're going to have a bigger heart attack. So that's why we kind of stay away. So if you get there first, the patient has nitro, the medics are extended, you're going to be treating this patient, you're going to be transporting this patient, you're going to be hoping for an intercept on the way to the hospital, and they're having chest pain, they have a prescription for nitro. In the back of your mind, you're thinking about maybe giving them the nitro. Just remember, blood pressure has to be over 120. They should not have taken ED medications. And the last thing is, if their pain is more indigestion type pain, I would hold off until they get a 12 lead EKG, even if that means holding off till you get to the hospital. Okay. Okay, so that's angina. Now, the acute myocardial infarction. So here it's the same fat that started the problem, okay, and it's the cap that grew over it, except here the cap ruptured. So picture you have a garden hose. On the inside of the garden hose, there's some junk, and then the protective covering grew over that junk on the inside of the artery. And then a couple of months later, that cap over the junk ruptures. And we'll talk about why it ruptures in a second. So what happens when this happens in a blood vessel in the body thinks that rupture of the plaque is a cut, is a wound. And you know what substance, what blood cell does it send whenever you have a cut? Platelets, right? That's what makes the scab. That's what stops the bleeding. So now you have this little rupture of this plaque deposit on the inside of your artery. Platelets, Gesundheit, platelets start covering it. And the platelets don't stop with like one little gentle cover, right? You've seen scabs, they get bigger and bigger. So what does it actually do? All those platelets go there and stick, and they actually shut the artery off. Now, they don't shut the artery off in 5 minutes. This is a progressive problem, okay, which is why the patient has time to be treated in the hospital. But a true heart attack, right, 95% of heart attacks is what they call a thrombotic event. So the thrombus is the area inside the artery where the fat was. Because of the plaque rupture over it, okay, it causes platelets to stick. And I think I have a picture of it. Hold on one second. Yeah. So here's your inside of your artery, right? The center of the artery is called the lumen, okay? Arteries have 3 walls. They have an outer wall, a middle wall, and an inner wall. And then what happened here is this is a bad drawing of like fat that accumulated. And this little yellow covering over here is where the inner wall has kind of covered the fat. And then that fat ruptured. Okay, that plaque, not the fat ruptured, but the cap ruptured. And the body now sends platelets, okay, to start covering up the perceived wound. And this will continue to stick, platelets stick on each other. It's called platelet aggregation or platelet clumping. And it'll eventually close off this blood vessel. And then they have a big problem because now they have a part of their heart that's not getting oxygenated blood. So whether it's ALS, BLS, we have an emergency treatment for those patients that will actually be the most important treatment they will receive in their heart attack, which is the early administration of chewable baby aspirin. Aspirin interferes with the ability for platelets to stick together. So by giving them the aspirin, okay, you're going to prevent any further blockage. So if somebody had an onset of chest pain and popped aspirin right away, they probably have no blockage. But again, people don't do that. So let's say somebody's been having pain for 45 minutes before we get there, and they have another, I don't know, 15% more occlusion. Now you give them the aspirin. That occlusion that they had prior to the aspirin is going to stay there. Okay, but you will prevent any further occlusion from occurring by giving them the aspirin. Now, the only patient in the setting of a heart attack that should not get aspirin is the patient who has a history of anaphylaxis to aspirin. Okay. Sometimes that's a little hard to differentiate because you may say to the patient, you know, well, because you're having chest pain, we'd like to give you some aspirin. Is that okay? That's called, you know, informed consent when you ask a patient, you know, can you do something? So, and they say, no, 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 my doctor said I should never take aspirin. I used to take it and it caused some problems in my belly. I was bleeding and he told me I should never take it again. So there, the patient didn't have an anaphylactic reaction. The patient was taking aspirin for a long period of time, probably for arthritic pain, and developed some bleeding in their belly, which is not an uncommon side effect of long-term use of aspirin. Your setting that you want to give them aspirin today is a 1 shot, 325 milligrams, which is probably half the dose they were taking when they have arthritic pain. Okay, like when we used to use aspirin for headache, an adult took 650 milligrams. For a heart attack, we give them 325, so we give them half the dose. and you're giving them to them once. So really, the benefit of the aspirin outweighs the risk of any possible bleeding because they're probably not going to have any bleeding. So you would have to say to them, if you're having a heart attack, the aspirin is very, very important. Okay. So we'd like to be able to give it to you if you'll give us permission. But if you don't want us to do it, then we won't. And, if they say no, you can't give it to them. I'll tell you that they will get it in the hospital. They'll give the same story in the hospital. They'll say, no, you need to take it. And they'll be like, okay. But again, from an informed consent standpoint, if the patient's refusing, then we just can't give it to them. Just make sure you document on the PCR that you asked the patient for permission to give aspirin and they refuse to give it to you, because that's one of the things it's one of the things that the hospital on every heart attack patient has to document the time the patient got aspirin. So if they say on their chart that they did not give aspirin, they have to be able to track it back to our chart to know that patient did get aspirin at some point. Okay. So again, the only true patient that does not get aspirin would be the patient has a history of anaphylaxis to aspirin. Now, as far as like outcomes of heart attacks or even outcomes of angina. So we said that, as we get older in age, our arteries start to get narrowed because of our diet, okay? That our arteries start to get stiff because of the calcium in our diet, and stuff like that. So the body just doesn't say, oh, well, you haven't eaten well all your life and now you're going to have big problems. What it actually does is if it senses a certain area of the heart has been deprived of oxygen because these blood vessels are getting narrowed, it actually grows more blood vessels in that area. And that's called collateral circulation, like when you have collateral on a loan, right? So collateral circulation is what keeps older people going later in life. Now, the reason I bring it up is you've all heard the story of the 80-year-old guy who says to you, I've had 3 heart attacks and they were all minor, and the doctor said, don't worry about them. And I didn't even have chest pain. He just picked it up on the EKG, right? That type of thing. But you've also heard of the 20, 30-year-old who had a heart attack and, had a massive heart attack, died, or had a lot of damage and stuff like that. So collateral circulation is the difference in that. The 30-year-old did not develop collateral circulation. So when he had this event and he blocked off an artery, there were no other arteries that had grown in that area. So he had massive muscle damage to his heart. The 80-year-old, okay, because of the fact that he had this, slow progressive disease, this cardiovascular disease, coronary artery disease, okay, he's grown multiple blood vessels in multiple parts of his heart. So now when you occlude off one blood vessel, there's other ones in the same area that are providing the heart with oxygenated blood. So they don't tend to have as bad of heart attacks if they develop collateral circulation. I mean, obviously not every patient develops collateral circulation. So there can some older people who have a bad outcome too, okay? Now, other than aspirin, the next most important thing for people having a heart attack is they get to what's called a primary angioplasty center, okay, which is a place that can do emergency angioplasty. So right now in Rockland County, that's Good Sam, but by the end of, well, maybe not the end of 2020, but by mid-2021, NIAC will also be a primary angioplasty center. So for you guys, that would be much quicker. So either one of those two, and then I know you go to Englewood, which is also a primary angioplasty center, and Valley is a primary angioplasty center. I don't believe Pascagoula Valley would be, because that's kind of they funnel everything to Hackensack from there. So I would assume that Hackensack is the primary angioplasty center for Pascagoula Valley. But Valley Hospital, Englewood, Good Sam, and at some point when they let us know that they have approval, COVID held up the approval, so they would have already had the approval if it wasn't for COVID. You would have NIAC Hospital as a choice, okay? Now, oxygen could play a role, but again, that goes by their pulse oximetry. If they're already satting normally, and normally is 94% or higher, then they don't really need a lot of oxygen. You can just put them on nasal cannula at a liter or two. They don't need more oxygen really because they're satting normally. So that's the main treatments we have. So the number one, well, first of all, the number one difference between angina, okay, and a heart attack is angina is a temporary episodic situation brought on by exertion, okay, whether it be psychological or physical, that once that exertion is removed, it typically goes away. So there's no permanent damage. Where a heart attack is an actual blockage of a vessel or a very, very narrowed vessel, okay, and they're not going to get better until that vessel is opened up again. You can improve their prognosis by giving them aspirin, but eventually they're going to need angioplasty to open up that blood vessel and stent open that blood vessel. Okay. Now, what about if somebody tells you 4 days ago I had, 4 stents put in, and today I have chest pain? Could that happen? So yes, it absolutely could happen. It could be one of multiple things. It could be that they just blocked a different vessel that had nothing to do with their stenting, or it could be that actually the stent got occluded, right? So sometimes the stent itself gets occluded, especially if they're not using a drug-eluting stent. So don't say to somebody, who calls you and says, this happened to me 4 days ago and now I feel like it again, that it's probably nothing, because it probably actually is another heart attack. They're just not, a very, very lucky type of person. Okay. Okay. So any questions on the heart attack patient, the angina patient, or anything like that? Okay, you still with me? Okay, anybody still with me?
Yes. Yes.
Okay, okay. So let's talk about a couple other conditions, and then we'll call it a night. Okay, so congestive heart failure and acute pulmonary edema. So they're really one and the same. One is a chronic condition that someone lives in day to day, which is congestive heart failure. And when they have the emergency and they call us, it's called acute pulmonary edema. So what is congestive heart failure versus acute pulmonary edema? So, basically what happened is that the left ventricle has become weak and damaged. Could be a heart attack, it could be old age, it could be an infection like these pericarditis, myocarditis is down here. But the long and short is, the left ventricle pumps to the rest of the body, right? So when the left ventricle gets damaged and can't empty completely, blood starts to back up into the heart. So if the left ventricle can't pump, it backs up into the left atrium. Now, if the left atrium gets backed up, that backs up into the pulmonary vein, and then the pulmonary vein backs up into the lungs. And what happens is that the blood vessels that are surrounding the alveoli, the air sacs, start to get swollen, and they leak plasma, which is the fluid portion of the blood, into the alveoli. Now, these air sacs, the alveoli, the only thing they should have in them is air. So if they get fluid in them, the person feels like they're drowning. And that's what congestive heart failure, acute pulmonary edema is. Congestive heart failure is not so bad. Day to day, they live with it. They watch their salt. They're taking medications. These are the people we see with swollen ankles, okay, maybe some jugular vein distension. They sometimes have to sleep sitting up, but they manage it day to day, okay? When they feel like they're drowning and they call us and they're all hyped up and we can't, anything we do, they're fighting with us. We try to put oxygen on them, they pull it off and everything like that. That's the acute pulmonary edema patient. That's the patient where their alveoli are so filled now, they feel like they're drowning from the inside out. They call it a dry land drowning, right? And I mean, they're on dry ground and they feel like they're drowning. And some of them are so bad, okay, that you actually see that fluid coming up, their alveoli up into their trachea, out their mouth. They have this foaming, almost looks like a frothy sputum coming out of their mouth and stuff like that. And, years ago, it was really not a whole lot we could do for them. We used to try to put them on a non-rebreather. They rip it off because these people don't have oxygen hunger. They don't crave oxygen. They crave air. And when you put a non-rebreather over their face and they already feel short of breath, to them, it feels like you're suffocating them because there's not a lot of flow out of a non-rebreather. So they were very difficult to manage. You couldn't even get them to sit on a stretcher. They wanted their legs to dangle. They didn't want to be sitting up. It was too hard for them to breathe. And, basically we fought with them all the way to the hospital, and they used to wind up getting intubated and put on a ventilator and all this stuff. Now we know we have CPAP, right? Continuous positive airway pressure, as a treatment for them. And what CPAP obviously does is it pressurizes the lungs, the alveoli, the whole airway actually, and it helps to keep that fluid out of the alveoli so that when they open their mouth to breathe, okay, not only is oxygen going into them, a higher concentration of oxygen, but it's pressurized so that every breath they feel like, they're getting it into their lungs. They feel the sensation they could actually breathe again. Now, nothing is perfect. So the problem with it is the same claustrophobia that the patient feels when you put a non-rebreather on them, they feel when you put CPAP over them, except it's magnified 100 times because the size of the CPAP mask and how it has to be tightly fitting to their face to work, right? Because it's a pressure system. So if there's any leakage, you don't get the CPAP effect to it. And so now you have somebody who's confused, nervous, fighting with you, and you have to convince them to put a CPAP mask on. So some people are successful, some people are not, right? Some people are very good at convincing patients to put it on. Some people are not. It's hit or miss. Every patient's going to be a little different. What I have found is that if a patient has this condition and they've had CPAP in the past, they will ask you for it, or they will actually help you put it on, and it's much easier to get it on those patients than the first time person you're trying to put CPAP on who never experienced it before. And those patients, definitely can be difficult for putting on. So I wouldn't fight with them in the house. I wouldn't fight with them in the ambulance. I would start transporting and as best you can try to get it on. Okay. It only works if it's a tight fit to the patient's face. It shouldn't be so tight it's uncomfortable, but it has to be a tight fit because you have to generate pressure under the mask. If it's a loose fit, the air will just leak out under the cushion in the face and not, get into the lungs. Okay. So that's CPAP, and that's a thing that we don't use too often. So it would be a good. I know you guys do your fast track drills at your meetings. That would be a great, fast track drill. I would say to do at least once every 6 months, to bring it in and do that. Okay. Maybe you can get like Glenn or somebody, or you know, to go over it with you, or somebody who feels comfortable in using CPAP. But that would be a great drill to do. Now, the last thing I put down there is,
Frank, I
yeah,
have a question.
yes,
When people have sleep apnea, is the
same,
CPAP what they use?
yep, same thing. It just may be
Same thing?
it may be a modification. So
Oh, okay.
interestingly, right? So I had a community paramedic patient the other day. So when they talk about CPAP, they talk about pressures, right? In other words, what pressure is under the mask. So on an EMT level, I believe they limited you to 10 centimeters of water pressure, which in all honesty was like half of what this guy was using for sleep apnea. So I don't know why they made it so low. Well, I do know why. They're probably afraid of like a pneumothorax or something like that, which is a very rare complication of CPAP because, obviously you have people with sleep apnea that are on it every day for the rest of their lives and they don't have pneumothoraxes, or a small percentage of them may have a pneumothorax. But yes, so I have to go back and look at the BLS protocol. I think it used to be 10 to 15 millimeters of centimeters of water pressure. Now I think it's 10 centimeters of water pressure. And I don't know which device you use, but the way most of the devices adjust the pressure is by the liter flow that you set the oxygen tank at. Some of them have dials on them that you click to certain numbers. But again, that would be another good thing when wherever you keep your CPAP, you should label it on how to use it, because people are not going to be using it routinely. It's going to be obviously an emergency setting when they're using it. And, that's not the time to try to figure out how to use it or how to put it on the patient. Because I'll tell you, you only really have one shot to get it on them. If you start fuddling with it and, I don't know, you put it on them upside down, or you put it on them without enough oxygen flowing through it, and they feel like, they're going to feel like you're suffocating them, and they're never going to give you a shot again at doing it, right, by the time you get to the hospital. So you do need to be proficient, in using it. And it's tough. I mean, it's tough. The old ones we used to use took so long to get it on that sometimes people would be at the hospital before they got it all hooked up. The new ones that are disposable, are one shot, and one shot, use them, to dispose of them. They're a little easier to put on. So, but yes, CPAP for sleep apnea is the same technique. Okay, the mask for sleep apnea, it can be a full mask, but a lot of times it's just one that sits over the nose, so it's a little more comfortable. Depends on how bad of sleep apnea they have. And remember, people die every day of sleep apnea. A lot of times people don't know that's what people died of, but if you do have a spouse, okay, where what basically you'll hear is snoring with periods of apnea, right? So they're snoring, and then and then the snoring obviously is the partial obstruction of their tongue, and then all of a sudden you'll hear like a type of sound, and that's their apnea period. Okay, so if you're hearing that, that's somebody who has sleep apnea. So they do need to get a sleep study, and they're probably going to get fitted with some type of device. The problem with it, like anything in medicine, is since it's become a little bit of a moneymaker, you got a million different places running sleep apnea labs, and obviously they're going to want you to need a device, because that's how they make their money. They make money for testing you, but they make money on the device too. So if you have Gucci Deluxe insurance and you go to a sleep apnea lab, you can be pretty sure that you're going to be walking out with a $1,000 sleep apnea machine, whether you need it or not, just because you have Gucci Deluxe insurance. Okay, and then the pericarditis is the myocarditis is the endocarditis. So the reason I put this down here is one of the side effects of COVID that's becoming known. Well, there's the neuro effects, okay, which there are people who have cognitive deficits and stuff like that who've had have had a COVID. The other issue is the inflammation in the blood vessels. So it ranges from people having what they call COVID toe or COVID foot, where they actually have such poor circulation in their toes and their feet that they look like they have frostbite. They look like they have trench foot, and stuff like that. That's actually not uncommon in kids as one of the symptoms they see. And remember, a lot of times in kids, they could have been totally asymptomatic as far as the cold and the chest cold and the fever and all that stuff. And what will happen is typically about a month after they were exposed to the COVID, they'll all of a sudden notice that their feet hurt and they're sore and they have these, wounds on them and stuff like that. And it's called COVID foot. But they're even finding now that there's blood vessel changes, and this can happen in all ages, from kids to older people. There's changes in their blood vessels resulting in heart problems, resulting in stroke-like problems. We had a 13-year-old boy the other day who had a stroke. And again, he never tested positive to COVID, but they did an antibody test and he had COVID antibodies. So they're assuming that his stroke was secondary to the inflammation of his blood vessels from the COVID. So, just something to realize for probably, going forward until COVID is not a thing anymore, is that when you have these weird presentations of things that you can't figure out, COVID may actually be the culprit. Okay. So again, you could have somebody who gets a bad infection in their heart. It could be COVID, or it could just be they're not lucky and they get a infection somewhere else in their body. It travels to their heart, and they can get very sick very quick, because remember, the heart is the main pump of the body, of the blood vessels. So if the heart has an infection in it, it's not going to be able to pump effectively. So, just something to think about, like a pericarditis patient, right? So pericarditis is an inflammation of the pericardial sac. There's an infection in the sac surrounding the heart. So that presents exactly like a heart attack. They have chest pain, they may be short of breath. But the difference between a heart attack, just to think about it, if it's an itis, right? If it's an infection, what are they going to have that a heart attack patient typically will not have? A fever, right? So typically people having heart attacks are scared, so they have cool, pale skin. People who have infections like pericarditis and myocarditis and stuff like that, they have an infection going on, and there's a fever. So they usually have warm, sweaty skin. So you have somebody now with chest discomfort, and they have warm, sweaty skin, and a history of this being slow progressive over a week, okay? It's probably more of an infectious etiology. Remember, a pneumonia patient can have chest pain. It's not their heart, it's probably their lungs, right? And they probably have a pleurisy, like an infection of the lining of the lung. So there's a lot of different ways that it could present, this chest discomfort, not that it doesn't always have to be doing with the heart. And then the last thing with all of these is just remember there's the atypical presentations, right? So who can be having a heart attack and not have chest pain? So, you've told me this in the past. It's the diabetic patient because they have neuropathies. It's the elderly patients, again, because their nerve endings start to break down as they get older. And women, just as a broad category, a lot of times have presentations that don't lead us to believe it's a heart attack, right? So they everybody's predisposed to thinking women don't have heart attacks, which they do. And a lot of times women have more of those inferior wall MIs where they have more GI symptoms than they have chest pain. So when you get those two things combined, where we have a little bit of a prejudice in medicine to say women don't have heart attacks at the same rate that men do, plus they have the non-typical symptoms, they definitely get slower care than a male patient who goes into the hospital with chest discomfort. Okay, so let's finish up. So we know all the things that we typically ask, right? So, chest pain, pressure, there's an elephant sitting on my chest, there's a belt tightening around my chest. The inferior wall events can cause abdominal complaints. The OPQRST is what to remind us to ask questions. So onset, what were you doing? Provocation. Actually, let's stop with onset here. So the onset of angina would probably be exertional, right? At least stress, some type of stress, whether it's psychological or physical. What's the onset of a heart attack? What does the typical person having a heart attack tell you they were doing when the pain hit them? Nothing. They were sitting there. They were sleeping. They were eating. Nothing exertional, because the plaque rupture doesn't require exertion. Okay, it just happens. There's certain things that raise your risk of having the plaque rupture. So anybody who's been to the dentist, they have pamphlets or they have signs up on the wall saying that getting your teeth clean decreases your chances of having a heart attack. And that's 100% true. Any chronic inflammatory process like gingivitis, arthritis, having wounds that are not healing, like in diabetics, even picking your cuticles to the points where they become red and inflamed constantly. Like some people are stressed and they start picking at their cuticles and stuff like that. All of those release a hormone in the body, okay, called cortisol. It's a stress hormone. And that acts on that fibrous cap over the fat, and that weakens it. So stress, whether it be psychological stress, physical stress, being run down and tired, high blood pressure is not good for it. All of those increase your odds of having a heart attack. But in all honesty, a lot of people just have heart attacks because they're not lucky. It just happened. They had a thin cap that was weak and fragile, and it ruptured. And once it ruptures, the platelets go and the whole thing starts to happen. Once the platelets start hitting it, it closes it off, okay, and they have, the true heart attack. So we have onset, okay, provocation, does anything make it better or worse, okay? We have quality, can you describe it to me? What does it feel like? Radiation, does it go anywhere? So, years ago we used to say people having heart attacks had pain radiating to their arms. I don't see a lot of people telling me when they have chest pain it radiates to their arms. I've had people tell me that it radiates to their jaw, it radiates to their back, it radiates to their neck. But the arms, I don't know, at least from my experience, not so common, but it could happen, okay? Severity on a scale of 1 to 10, with 10 being the worst. So somebody having angina, you'd expect them to say they had a 10, 9, 8, okay, to start with, and it slowly started getting better, okay? So the number started to drop, okay? Somebody having a heart attack is probably going to say to you, it starts at a 5, and it's increasing as time goes on. It's not getting better because they're two different etiologies of what's happening. And then the T is time, in other words, how long has it been going on? Depending on the type of heart attack they have, they may have shortness of breath. So dyspnea is shortness of breath. Orthopnea is shortness of breath depending on the position, okay? Again, heart attacks that typically involve the left side of the heart result in shortness of breath because they get the pulmonary edema aspect of it. Diaphoresis is the cold sweat that somebody breaks out into when they're scared. So again, somebody having a heart attack is typically scared. In fact, the treatment in the hospital is, or even in the field, is we give them analgesia, we give them pain medicine to relieve their pain, because the more in pain someone is, the more adrenaline is released into the bloodstream. And adrenaline only makes the heart work harder. So if you're having a heart attack, you actually want the heart to work less, right? You don't want to exert it. So a lot of times people having heart attacks will get analgesia like morphine or fentanyl, will get beta blockers to kind of relax their heart and slow down the beating action of the heart. Now, people that are scared get restless, they get anxious, and trust me, people having heart attacks are scared. The feeling of impending doom. So if you ever have a patient who says to you in the midst of a heart attack, I feel like I'm going to die, I can't keep my eyes open. So a lot of times people prior to coding will actually have that sense of impending doom. If that person actually codes in front of you, that would be the one time it's probably still okay to give a precordial thump and to punch them right dead center in the middle of their sternum, because it's technically supposed to be a monitored witnessed arrest. So a monitored witnessed arrest means that you had them on the heart monitor and you saw them go into VFib. But I'll tell you, I've had people who coded in front of me, and it's pretty much always the same, that they say, like, I don't feel like I could stay awake again. Sometimes you'll see their eyes roll back into their head. They'll have some brief seizure-like activity, and they'll become, limp, apneic, not breathing, no pulse. So they basically went into VFib in front of you. That's the only time a precordial thump may actually convert the VFib, at that second that they go into VFib. So if you saw that and you haul off and you punch them in the middle of the chest and they wake up and say, what happened? It's one of two things. They just closed their eyes and you punched them for no reason, or they actually went into VFib and you converted them. So either way, you could say you saved their life and feel good about it. Okay, nausea and vomiting, very common of the inferior wall MI. Fatigue is the #1 complaint of a diabetic and elderly patient having a heart attack. So you go to a diabetic, you go to a 80-year-old person and they say, I have no energy, I feel exhausted, I feel tired, I just don't feel myself, maybe I'm a little short of breath. That could be a heart attack in those patients. Again, because of the neuropathies, the nerve ending damage, they don't feel the pain the same way, okay? Just like you should always, anytime you go to an old person, especially if it's a woman, and the story is they're just not themselves, they're a little confused, you should always assume a urinary tract infection until proven otherwise, okay? So you know, you go to an older person, tired, weak, run down, the two things you always want to think about are a urinary tract infection and could this be an atypical heart attack type of patient, because they're not going to present the way that, you know, you would expect them to present. Palpitations, sometimes people go into fast heart rhythms, SVTs, VTAC, and stuff like that, that can generate chest pain because the heart is working so hard. So if they tell you that it feels like their heart is pounding and you check their pulse and you find it very weak and thready, their probable cause is that they're in a tachycardia. I'm sorry. And that's the cause of their heart attack. I mean, that's the cause of their chest pain. They're not actually having a heart attack. It's that their heart is racing too fast. And again, unfortunately, on a BLS level, there's nothing you could do but get them to the hospital. But on an ALS level, we have certain medications or certain treatments, you know, electricity and stuff like that, that we could do to try to slow it down if they're very symptomatic. And we talked about the atypical presentations in the older people. Okay, so let's just review the meds and then we'll call it a night with the cardiac problems. So again, make them comfortable. The more comfortable a patient is, the less adrenaline release. So have them sitting, okay? Maybe if they have a big belly, loosen their belt a little bit so that their belly is not pressing up against their belt. Oxygen, again, if their pulse ox is above 94%, they probably don't need a whole lot of oxygen. So the new protocol says oxygen is appropriate. So if, you know, if they are sat at 94% and you want to defer oxygen, that's fine. From a medical legal standpoint, I'd probably still put them on a liter or two just to be safe from a medical legal standpoint. They probably don't need it, but just to be safe. Aspirin, again, as long as they don't have any allergies. So they get 4 81 milligram aspirin, which comes to about 324. Each one is about 81 milligrams, so 324, 325. It's usually rounded to. Okay, and if the patient has a history of angina, okay, and has nitroglycerin, you can assist them with taking their nitroglycerin. We talked about they should not be taking any of the ED medications, that their blood pressure should be above 120. Okay, nitro we said is a maximum of 3 doses, 5 minutes apart. You can keep on giving it to them up to 3 times as long as their systolic blood pressure never goes below 120. Okay, you're supposed to obviously monitor the blood pressure consistently, and that patient has to go to a primary angioplasty center. Okay, you're not going to be able to differentiate. Well, I shouldn't say you're not going to be able to differentiate. Either way, whether it's angina or a heart attack, acute myocardial infarction, they're going to go to an angioplasty center. But when I said differentiation, so I mean, if you had somebody who told you they had terrible pain while they were running for the bus, and between the police putting them on oxygen, them sitting down, and us coming and relaxing them, the pain went away completely, they're probably not having a heart attack, okay? They're probably having more of an angina event, but still, by going to an angioplasty center, at least you know they're going to be able to get a diagnostic cath versus an emergent cath if they need it. So, it's still probably better to take them there, okay? So what does aspirin do? When we're going to use aspirin, we said it prevents the platelets from sticking together. Indication is somebody you think having an acute myocardial infarction. Are you going to hurt the angina patient by giving them aspirin? Absolutely not. Are you going to help them? No, but you're not going to hurt them. Okay. Contraindications be any allergy to aspirin. Okay. Now, the recent GI bleed. So in other words, let's say somebody's really unlucky and they got blood pouring out their butt and they're having chest pain. And now, do you give them nitro? I'm sorry, not nitro. Do you give them aspirin? Okay. Well, actually, you wouldn't even give them nitro. All of that would be a medical control contact. I would put them in the ambulance, start going to the hospital, and call medical control and say, listen, I got a guy setting an MI, crushing chest pain, but he's got a GI bleed. Do you want to give him the aspirin? I would assume they're going to say no, because one of the things it could be is that their chest pain or maybe more abdominal pain from their GI bleed. So they're probably going to want to wait to get to the hospital and figure out exactly what's going on. And I would be 100% fine with that. Okay, we talked about what happens when somebody has the typical heart attack with the plaque rupture and how the platelets close off the remaining part of the artery. We said aspirin is oral. They have to chew it and swallow it so it goes to work right away. Okay, and they take 4 81 milligram chewable baby aspirin. The new protocol addresses what if the patient took aspirin in the house before you got there. So what the new protocol says is if patient took the appropriate dose of aspirin, the appropriate way, then you could defer giving it to them. So in other words, a patient took 4 81 milligram chewable baby aspirin and chewed and swallowed them, and they are not expired, then you don't have to give them aspirin. But the protocol also says if you're not 100% certain that the aspirin is good, that they took it the right way, anything like that, then you should go ahead and give them your own 325 milligrams. So even if they got 2 doses of 325, that's still 650, which is about the dose people took when they had a toothache or a headache. So you're not going to hurt them by doing that. So the benefit of the aspirin, again, is so great in a heart attack that unless you're 100% positive they took it the right way, then you would go ahead and give it to them. Now remember, people may have 81 milligram aspirin at home that they take once a day to prevent a heart attack. That has a hard coating on it, okay? So if they told you they just swallowed it, they swallow 4 of them like they do, you know, they swallow 1 a day. So instead of just 1 a day, they took 4 because they thought they were having a heart attack. That is going to go to work in hours. So you, if they truly are having a heart attack, you would have to still give them your 4 non-enterically coated, without the hard coating, and tell them to chew and swallow it. Okay. So that's the aspirin type of situation. Oh, people also ask, what about people take a 1-a-day aspirin? Yes, you would still give them their, you know, your aspirin if they were taking a 1-a-day aspirin. People ask if somebody's on, you know, a blood thinner. Yes, they still get aspirin. Again, the only true contraindication to aspirin in the setting of a heart attack is the history of anaphylaxis to aspirin. So other than that, they pretty much should get aspirin. Okay, nitro, again, we're not carrying. A patient may have it because they have a history of angina pectoris. And what does nitro do? It relaxes the blood vessels. So we actually even use nitro in a heart attack, right? So in the heart attack, the benefit of nitro is only if they have that collateral circulation, because remember, the blood vessel that's closed off, that had that platelet closing off, is closed off. The nitro would help if there was any collateral circulation to open up the blood vessels in the general vicinity of that blocked vessel and get more blood to the area. And we said that angina, what it does is it just speeds up the relaxation of the blood vessels and then relieves the pain quicker. Okay. So contraindications, I don't know anybody who has an allergy to nitroglycerin, but it is in the protocol, so I put it there. Okay. Blood pressure below 120. I talked about the suspected inferior wall MI, and then we also talked about the erectile dysfunction medications, right? And we said that certain medications can also be used to treat BPH, okay? And that also you have the alpha blockers being used for BPH and stuff like that. Okay, nitro is 3 doses sublingual, okay, not all at one shot, obviously 5 minutes apart, as long as the blood pressure stays above 120, and the route is sublingual. Okay, so I think what time is it? I think we're gonna stop here, okay, because everybody's been very quiet. Does anybody have any questions on anything we went over tonight, or any questions on anything in general?
No, no.
Okay. Okay, so everybody have a good night. I will send out the quiz in a couple of minutes, and I guess we'll reconvene again in October. And depending on what happens with the uptick of COVID and stuff like that, you know, maybe I'll talk to Pete and everybody, and we'll make a decision if at some point we're going to start doing stuff in person again, or we'll continue. Are you guys actually, have you opened up the building again, or like what's going on down there as far as meeting in the building and stuff?
We're open for meetings, Frank.
You open for meetings? Okay, so we'll figure out what we want to do depending on the uptick and stuff like that. Okay? So I'll send everything out. Everybody have a good weekend.
Thank you
Take
too.
care. Bye-bye.
Have a good night.
Take care.